Hi, hello. Thank you very much for the invitation. I'm, like he said, I'm from France, from Foch Hospital, and I will like to talk to you. This is my conflict of interest. Screening. I think there are some national programs of screening in some countries. In my country, we don't have a national screening program, but every hospital has a screening program because the studies are showing that if you will reach out the lymph nodes before, we can save, and the mortality will be less than 20% for lung cancer. A little bit of history. Everything that we are doing now, it's from Gustav Kilian, who developed the flexible endoscope, because before, like you know, the rigid bronchoscopy with for the diagnostic. Now bronchial endoscopy is the first line examination for the proximal region. And like he said, the EBUS technique for the lesion in contact. There is no accessibility for peripheral lesion. Now we are doing a lot of CT-guided biopsy with a high diagnostic sensibility. I think you know this, but I don't know if you know that pneumothorax, it's 25%. For me, it's a lot. It's 1 in 4 patients. And of course, there are some limitations. I put some patient in here, emphysema with a bulla or a pneumectomy, and if the lesion is close to the main vessels, or if it's a very small nodule. The intermediate zone, because I speak for the proximal zone and for peripheral zone, it's more difficult to reach out. You have to follow a predicted path, because the bronchial tree is a complex bronchial structure, and you have to have the endoscopic equipment of small diameter. This is with ultrasound probe, the tools, and the endoscopic. Which endoscope? I think everybody is using the normal one. This is the standard one. This is bigger for the foreign bodies. And you have the new ones, the fine endoscope with a diameter of 4.2 and with a working channel of 2, where you can put the forceps. And the ultrafine that has 3 millimeters. You understand that you are going very, very far away, with a working channel of 1.8. And the pediatrics one. Ultrasound probe, it ensures proximity to the lesion, and it's very interesting because it's reutilizeable. Can be used alone for the lesion, like I told you, with the endoscope of 3 millimeters with a working channel of 1.8, and can be used with a sheath guide that you can see in here in the picture. This is the sheath guide, and this is without them, the ultrasound. Sheath guide don't improve the diagnostic of the lesion, but it's very important because he has a lower number of complications, because you put it inside and for the bleeding and everything. These are the tools that you can use for the ultrasound. You have the needles. Sorry, you have the needle in here. You have the brows, the forceps, and this is the guide sheet. And for the angles, if you are in the bronchial and you cannot go in the, if it's very, very in the lower lobe and you cannot go, this tool will help you to make the angle. To visual better and to understand a little more how it's happening. Sorry. This is the scope that I talked to you about, with 4.2 millimeters and working channel of 2. This is a standard one that you are living in the proximal area, and the fine one that can go much further. This is the guide sheet that keeps in place, and you can do the brush, and after with the forceps you can do some sampling. Tuk, tuk, tuk. Bronchial sign is very, very important for you when you choose your tools and your endoscope. At the beginning, in 27, you had 5 different lesions. You have the one with the bronchial, it's not one, with the bronchial that reach in the nodule, the bronchial in the peripheral of the lesions, and after, because we are all doctors, we are saying that the artery is near the bronchial. That's why for the next type of bronchial sign, it said if the artery is in the middle of the lesion, or it's the artery, it's a peripheral of the lesion. They thought it was a little bit complicated to understand, so they make much simple. You have the bronchial in the lesion, there is a peripheral, or you don't have the bronchial in the lesion, it will be much difficult to reach out your nodule. This is a patient that we did to understand that we are complementary and we can work with the radiologist and everything. There is a patient that had a lymphoma, and they found this lesion in the lungs. First, we thought it's a big one, it's in the peripheral, we will have a CT guided peripheral. But unfortunately, if you have this image, you understand that they have the sample in here, maybe in here, but this, maybe it's an atelectasis behind the lesion and didn't have the diagnostic. And for us, it was very simple to have diagnostic because in the bronchial, we had the sample and the diagnostic, it was on his lymphoma. I have, in my hospital, I'm the responsible of the bronchoscopic approach for pulmonary nodules, guided with the images. And I have to tell you that it's very important to plan your working and how you will get to the nodule. You have to see the CT scan in the frontal, axial, and to understand before that you are going to have these samples, where is your nodule, and to have you also some plan to see where are you going from. Localization of the nodule, or the lobe, the segment, or what branch. You have to understand that there is a difference in the volume lung with general anesthesia, and you have to make you have to try to make the same, because you have to understand that the patient had the CT scan with apnea block. And with the general anesthesia, the patient will breathe a little because the anesthesia will not give you 5 minutes without breathing. That's why sometimes the nodule will change a little bit the localization. And also you have to understand that the upper lobes are better or simple to read because you don't have the diaphragm that will move a lot with breathing. I told you about bronchoscope sign, and you have to, sometimes the patient, when he's asleep, they can have atelectasis, and you have to understand, sometimes the mini probe will tell you, you can be in the lesion, because you have, the patient is not very well ventilated, and he has some atelectasis, like the patient that you see before. And if you are doing the sample in the patient with the atelectasis, you don't have the diagnostic. Pathway draining before that, and final confirmation by the radial EBUS when you are in the nodule. This is my experience. We began in 2018. At the beginning, we didn't do a lot of nodule because we didn't know what is better to do. Now we are doing a lot of nodule, but we are saying our diagnostic yield is not very good. And we saw the studies. What are saying the studies? This is a meta-analysis that's saying everybody's doing like this. Everybody's having this diagnostic. And we have to look at our patients. What do we have the patient? It's important to have, and when you see the patient in consultation and when you program the procedure, you have to have the better way to achieve the lesion. You have to don't have a CT scan very old, because you can have some liquid and the lesion will move away and it not will be in the same place like you saw. That's why I will recommend to you not more than 3 months CT scan before you're done. This is another patient, and you can see the bronchial sign. The bronchial is coming in the middle of the lesion. This is another patient that my radiologist said to me, I will not do the sampling, you can do it. And I understand him because he has a lot of emphysema, like I told you. Another patient that has a little bit of necrosis in the middle, and my radiologist, even if there is a bronchial, he said to me, it's better for you than for me. This is a patient that I think you should start with. It's not very far away. You have a lot of bronchial that reach in the lesion. And you should start with a big lesion at the first of your experience. The same for this patient. It's not far away. But my radiologist said to me for him it will be a little bit complicated. This is another nodule. You can have in here the bronchial sign with a little lesion. This is all my patient for the last weeks, and that's why I put it here. How we can do better? Because 17% is not, it's not 19% the radiologist. You have to have the bronchial sign. You have to know that malignant lesion has a better diagnostic yield than the benign ones. Of course, if it's bigger, I told you, it's much simpler to have the diagnostic. We have to think, we don't have yet the answer, but maybe the cryobiopsy for the green glass lesion. Very, very good to look at the CT scan before and imagine your project. There is another subject of the rows. All the project that we did at Force, we started with rows. I think not everybody can have a pathologist in your operating room. But at the beginning, you can start with rows. And after, you have to see there is not very difficult to learn some normal cells, and after, if you are seeing the probe, you can see if you don't understand the cells, you can say there is something, and the pathologist will tell you if you are right in the lesion or not. And you have to talk with the anesthesia, like I told you, to reduce divergence and atelectasia in your patients. This is only some picture to understand when you have the radial EBUS and you will have an image like this, you are in the front of the lesion. And if you are having a little bronchial that is in the peripheral zone, you will have a little lesion like this. Like I told you, it's very important to see your lesion, because if you see only this, you will tell me there is no bronchial sign. But if you are looking like this, you will see, I have a little more bronchial that are going in the... I told you for the CT scan, not very old. You will choose your bronchoscope, like I told you, with the guide sheet or without the guide sheet. But don't forget that the guide sheet will help you to have less complications. ensure correct targeting, and you will choose if you want to do with the forceps, with the needle, or with the bros. We will want to have the diagnostic, but we have to think of the future also, because nowadays we are miniaturizing the therapeutic tools, and it's only a step away from the proposing local treatment when surgery is not possible, when radiotherapy is not possible. There are some little studies with the cryo, with the radio frequency, with microwaves, but I think this is only the beginning, and after we will see. And I think your question is, can we do better? My answer is, with what cost? They are only single use, and all the studies are doing with the CT scan. This is a study that shows that no, we cannot do better yet. Success of navigation, yes, we have 19%. But the diagnosis for the patient, this is important. This is for us, for IP doctors, because we are it's very good, we have the lesion. But for the patient, this is the much important. It's the same that I told you 17, but you can see in here, it's like this. What changed and what is better? I told you if the lesion is bigger, you have a better diagnostic. And if you have the broncho sign, it's better than if you don't have it. Not a lot of complication, but either of 1% of pneumothorax, 2% of bleeding. This is a study very, very important because it shows us till today we are still at 17%. Even if we have a lot of study, a lot of lesions, we are still at 70%. It's very interesting because he said, we have some new technology, but he said, we will look 10 years before 2012 and 10 years after. Before, we didn't have a lot of study at the lesion, and now we had a lot of study. Are we doing better? Can we do better? And the results are not yet. Because 10 years before we were at 17, now we are still at 70%. My conclusion for today are, you have to look very, very carefully to have the indication, because of course the surgeon wants a diagnostic before surgery and he will give you all the nodules, but you don't have to have a loss of time for the patient, because if you are choosing to have this, he will delay the surgery. Very, very good looking for the best pathway. The final confirmation is the ultrasound. CT to body diversion, it's nearly 2 centimeters with the respiratory moves. Lack of direct vision. The biopsy technique, you will choose your tools, brush samples, use fine endoscope. It's your choice for local anesthesia or general anesthesia. It's it's only a fibroscopy, it's not a short duration. Cost effective because the ultrasound is reutilizable. Not a lot of complication. I told you 1% for the pneumothorax and some bleedings. And we are doing everything for the future because we know that we can do better. You're not alone. Speak with your team. Speak with your pathologist, anesthesiologist, thoracic surgery. Speak with them. Oncology department reach out to us if we can do some samples for their patients, because I do already 300% of diagnostic. A patient with 2 lesions in the upper right lobe and 1 lesion in the same time. In 30 minutes, you can have 3 lesions without pneumothorax, without sin. Don't forget, fine endoscope, radial EBUS, guide sheet, and all the tools for you to choose what do you want. Thank you very much. If you have some questions, and I don't do this alone. You imagine that I have a lot of stuff with me, and everybody helps me to do what I dream about. And if you don't have any question, there is a hands-on, and we can speak and have some.
Thank you for your talk. I have a question about the PET scan.
Yes.
In sampling or finding the best way to do a CT-guided biopsy or going directly for bronchoscopy. For in my experience, sometimes when I don't get the sample,
yes,
and then I see the PET scan afterwards, we see, oh,
yes,
there's not the lightning is not really at the bronchial, and maybe in the behind the lesion. So is this something you're considering to use the PET scan before and guiding you away into saying, yes, I use the bronchoscopy or the CT-guided biopsy?
I cannot do PET scan to every patient because we are doing a lot of nodules and I cannot do the PET scan. But yes, like you said, not the PET scan, but I will do another imaging, maybe a CT scan, and I will see that it's somewhere else, and I have another pathway, maybe this pathway, and sometimes I will do the second one, to have some samples. After seeing what did I do wrong, how can I improve that, how can I, and I will change my tools also. Sometimes the brush is better than the brushing is better, yes. Or the needles.
Thank you, Daniela. Sorry. Thank you, Daniela. I have 2 questions. The first one is, what is the learning curve about the radial EBUS? And the second one, in the multidisciplinary reunion with the radiologist, oncologist, you don't fight with the radiologist? They don't tell you that there is my patient?
Yes, at the beginning was very difficult. They are our friend. If there is a radiologist, we love the radiologist. It was very difficult because our radiologists are very, very strong. They are not saying no, never saying no. Yes, we will try it. We will try it. They are doing a lot of lesion, very little lesion, or they are finding some pathway to arrive. And at the beginning it was, no, this is my patient, this is my patient. And slowly he understands that I think there are lesions for us and the lesion for them also. There is and with the screening we have a lot of nodules, and there is a way for everybody. And the first question? For the learning curve, yes. I think you don't have to begin, like I told you, with the lead lesion, because you will be disappointed, the oncologist will be disappointed, the radiologist will be it will be his happy day. You should start with the big lesion, not far away, because I think this is the step after you are doing an endoscopy and after you are going a little bit farther. Not very, you don't have to have a lesion very far away. Proximal and a little bit far, maybe 2 division. The patient is very good, and the oncologist will be, and everybody will have a lot of confidence for you.
Do you use?
You have to do it. You have to do the lesion, and after you will have your learning curve.
And
I think 50 patients. Sorry.
It's about the needles. Do you use the forceps every time, or do you use the Olympus FlexView needle? What do you use?
It's difficult to choose your tool before. Maybe if you see a lesion very round and you think about hamartochondrome or maybe carcinoid, you will use the needle. But before, you don't know. If I don't have with the forceps, I will use the needle. I will use the brush also, yes. But in 70%, the forceps.
Sorry, this is Ajanta. My question is, what is your experience with the ground glass nodules?
The ground glass, I don't have a lot of experience because the screening was beginning at the United States and in London also. They have a lot more experience that we have. We are having some green glass, but you have to choose your green glass because they are green glass, they are not moving. They don't have any kind of tissue, only green glass. And our question and their experience said, don't touch them. If they are not bigger in your review, there are not any movement, it will not change the green glass, you should not touch him. For me, I'm doing green glass, yes, but with a CT scan. Because you saw, this was, I put you a picture of ultrasound with green glass. It's not a tissue, but you will see it like something it's not normal, it's not the lung, it's not the air, but you are doing, and this image, you have to do a lot of patience to have this, to see it, you are in the green glass or there is something else. But you have to do a lot of patience, and it's better to start with the big ones, yes, when you're sure and everything. Green glass when you have a lot of experience. This is my opinion, but everyone.
Thank you for the good talk. I'm called from Malaysia. I'm just, because EBUS is always just a verification technique. So do you have any like VBN or navigation pathway for you to reach the lesion? Thank you.
Yes, I have navigation, but I think it's very important. We are IP doctors. You have to know it where it is, because I have navigation and he will tell me, go left, go right, because at the beginning everybody knows the segmentation, B1, A, B, but after you are losing in the, and it's very important for you to understand and to know where is the lesion, even if you are in the bronchial. But I have, yes, navigation who can help me, but not every time. And not every IP doctors in my hospital, they are using it.